And I think that's about it. I would like to begin by introducing some of our speakers. I will introduce our first speaker, Dr. Rebecca Cunningham. She is an associate professor of emergency medicine and also faculty in the School of Public Health at the University of Michigan. She's an alumni of our residency. Her research fellowship after her residency was under the mentorship of Dr. Ron May, who I see up there in the back, who we're very happy to have him here today. She's had an extremely successful career in injury research, culminating in the recent award of an Injury Control Research Center grant to the University of Michigan from the CDC. These are very unusual awards to be allowed to develop a research center at your site. So without further ado, Rebecca Cunningham will talk to us about injury research.
That's okay. I think we can get this going. I think I can talk loudly enough here. Let me know if you can hear me. First, an honor to be asked to speak today and to acknowledge Bill, as well as much of the focus and interest around injury research here over the past decade and the growth of the department, which has just been so stellar. So this being the science part also of our afternoon in acknowledgement. I was asked to both do acknowledgement as well as some science, so I'm a little light on the injury science, but I will give a little smattering there, which I was told I was need to do here, which will begin my talk, and then we'll get into a little bit more about kind of where we started as a center and where we've come and the departmental focus around injury. So an overview of this talk today is a little bit about injury in general, fulfilling our fabulous CME requirements today, as well as just some general education, a little injury epidemiology, a tiny smattering of the science of injury control and prevention, and then really we'll focus on our department around injury research and prevention, the beginning of that focus in our department, where it's gone, where we are today, where we might see that going, all with vision from Bill. So a little bit of introduction here. What is injury? Many people I find around the university don't realize they're doing injury-related research. They feel like they're doing traumatic brain injury research perhaps, they're doing toxicology, they're doing concussion research. They don't consider themselves injury researchers necessarily. Whoops, where did this go? And so one of our first tasks as I started to get more involved in promoting injury around the campus is to help people identify what they're doing is related to injury and injury research. A little bit of background, injury being the leading cause of death for people ages 1 through 44, with a number of deaths annually leading non-communicable diseases and infectious diseases. This stands globally as well, with injury being a leading cause of death globally. And I really enjoy these slides. With over 406 billion annually lost in productivity. When we look at this standard epidemiological slide here, for one of the things I like to think about, and I don't think I have a pointer here, but for all of our training in emergency medicine for acute care, focusing on sepsis, on stroke, on no offense, we love stroke, flu, viral hepatitis, HIV, really the leading causes of death from a public health perspective still in our early age ranges, in the blue boxes here, are unintentional injury, which is largely related to transportation, violence, which are the red boxes here, first, second, and third causes of death in the ages of life where we have the most work-life years, our most productive years in society, and then suicide and intentional injury. So from a public health perspective, this is certainly injury being an important focus for us, and one that really, as residents and as we're focusing on medical training and acute care, is something we're not as focused on, partly I think because it's so common. We don't think about some of the things that are so common. We don't think as much about what to do with the next crash person that comes in or the next laceration that comes in, because there's 30. They're not nearly as interesting, really, as the zebras that we're trying to figure out a diagnosis for. So a little bit of history from injury, thinking about it as a disease model. The first half of the 20th century, and still most places globally, and for those of you who have been more involved in our global programs here in Ghana and other places, unintentional injuries and even intentional injuries are really considered either human error, fate, God's will. These have not been seen as preventable issues, and We would hear that still a lot from folks in Ghana and Africa when we were doing a little bit more work there as well. This was just fate. This was an accident. This was unavoidable, and that was the philosophy. Prevention was based on educating people how to act safely, with no thought to really building safe roads. Motorized vehicles were built, consumer products manufactured with major design flaws, and that was really considered nobody's problem. This being the era of the jungle and occupational safety, and that's where we started. Injury, moving along, became a public perception that injuries were just, again, accidents, random, unexpected events. The way infectious disease at that point was regarded before the discovery of bacteria. Just couldn't be helped, popped up spontaneously, nothing to be done, really. And then at some point, we moved through an infectious disease model of public health, realizing that if everyone gets sick in the town, perhaps from the drinking water that's contaminated, maybe that's not the people's fault, or was a random event that happened at the end of that chain where everybody in the town got diarrhea. Maybe there's a pathogen involved. There can be a public health approach to how we could think about a systems level change. And this shift began in the 1920s, 1930s. We began by having poor driver performance was leading to increasing mandatory licensing of drivers, beginning of cars coming around. Again, motor vehicle crash at that point was human error and mechanical factors. Roosevelt called for automobiles to be made more crash-worthy. I won't make the direct parallels here, but they can certainly be implied at every step of these analogies with motor vehicle crash and manufacturers taking responsibility for cars. Those same factors can be applied probably to our gun industry as well. How can we make cars more safe for the people who are using them legally? How can we make guns more safe for the people that are using them legally? Is a similar argument that can certainly be applied across. But the concepts that the provisions made to vehicles, that there were things that could be done for vehicles to make them more safe. And if any of you have seen, which I don't have this clip here today, but the old 1950s big car that crashes into this tiny little car. I can remember if it was Toyota or Ford, which is a famous clip that they love to show at Tree. And the big car just crumples everywhere now. And the little car just crumples everywhere now in the air pockets where it's supposed to crumple, protecting the inside of the occupant, whereas the older car just simply wasn't made that way at all. So we made big strides and big changes and really changed the current state of theory around injury control. Then it's not a fate, not a random occurrence, not an accident. Please use the word crash. Principles of injury prevention similar to the control of infectious disease. And this model became very accepted to the public health community. It has a similarity when we think about it as a disease with other disease states. There's seasonal variation for anybody who's working in Flint in the middle of July and June. There's epidemic patterns, there's long-term trends, there's demographic distribution, and can be examined with methodologies very similar to other infectious disease and other public health model. It's hard to talk about injury or any public health model without one slide on the Hayden matrix, sorry. William Hayden was the first physician administrator for NHTSA with the landmark article on injury control in the 1970s. And since then, it's become a mainstay of injury control and prevention development. Really developing a two-dimensional approach to injury analysis, dividing things into agent, host, and environment into 3 phases, breaking down what could be done at each one of those phases specifically for crash, but then could be modeled for violence prevention and really for any host of injuries. There's things that happen at the pre-crash phase, the crash phase, the post-crash phase. There's things that can be done to break the chain of the crash at the vehicle end, at the human end, at the beginning, and all of these places, focusing on any one of these boxes has risk factors associated with it, has interventions, has intervention design, and can have solid science that could then impact the final outcome. So globally, our countries started to look, globally, many countries started to look a little bit more at injury control and prevention. And I like to throw up the Sweden example. It was just about the same time in our country that we started to think a little bit more rigorously about a science of injury prevention and control. And this slide is old, so it wasn't 15 years ago, it was probably 20 or 25 years ago. Sweden started to look for new long-term traffic safety strategies. Already one of the safest countries in the world, they lose traditional strategy planning, fighting speeding, drunk driving, promoting safety belts, and then started to think about how else they should maybe think about applying really a public health model to injury control around crash. And they came up with the idea of zero tolerance, which was a long-term goal that they decided their country would have, that no one should be killed or seriously injured within the Swedish road system. Shocking. They decided it wasn't ethically acceptable if people would be killed or seriously injured when moving within the road transport system, and then that it was the obligation then of the country to intervene some. Yes, wide open shock by Marie-Liz on to that this is not an individual responsibility, but it is a collective responsibility then that something could be done about. It's a much different way of thinking than we think there's many values and goals that are different between the Swedish model and the US model. So I'm not saying we're going to get there exactly, but I think it's interesting to ponder. So they drew inspiration from other areas in occupational health and safety. Go back again to the idea of the jungle in the 1930s, where if you were working on the line and you cut your hand off or you fell into the vat of oil, well, that was probably your problem, right? What were you doing there? Why were you there anyway? Or you were just one of 100, so what, right? And that's kind of was our original societal thoughts about, crashing your car on the highway. If the road was designed badly and the traffic flow was designed poorly and the lights weren't quite right and you crashed your car, well, you were just kind of in the wrong place at the wrong time, and that's an individual problem, and that's fate. So we'll really shift into it that people are going to make errors and mistakes and misjudgments when they drive. This is a fact. People are human. That there are clear biomechanical tolerance limits to the body, and that these can be well studied and measured and then prevented. That the chain of events, as I mentioned in that Hayden matrix, can be cut at many number of points to stop that transfer of energy, which creates injury. And that the emphasis for the responsibility for road traffic safety needs to be shared by the people that are designing the system as well as by the end road users. And again, I'll make this same leap that we're not quite there as a society yet for intentional injury, but we easily could be in sharing the responsibility for the more lethal types of violence that occur. So looking at the biomechanical things that you can study, it's very easy to draw the graphs. These are not complicated graphs. On the y-axis here, you see the probability of pedestrian fatality. If you are hit as a pedestrian at over 40 or 50 miles an hour, you have a 60 or 70% chance of fatality. Not particularly complicated. But so what can we do as a system to prevent that? The problem being, when you're walking across the street right here, the end user isn't aware necessarily of all of the kinetic impacts that are floating around them in their universe, nor do they have very much control of them, because the people are blind to the kinetic injury around them. So you can't put all the responsibility on the person who's crossing the street there. You have to design the system in a way that that person can be somewhat protected from the kinetic energy that's being transferred around them. This is really what the risk is to that person. If that person fell off this road ramp right here, they would have the same kinetic impact as if a car sped down the street and skipped that light. But they don't view it when somebody steps off a curb, or that mother there with the young child. They don't view that the risk of their kids stepping into the street is the same as them falling off the cliff, or they would probably treat that entirely street much different. Nobody would walk there. But that's not the way we act, because we, as end users of the system, driving around in our cars, walking on sidewalks, we don't think about the system this way, which is why we have to have a systems level consideration for safety. So Sweden went on and looked at different road risks and designed their roads differently, essentially, and in many places in the country. So, and we know that when you look at different roads, the road on the right has a fatality risk per kilometer per year of about 200 fatalities per year. It's this is a road, I think in India, where you have multi-road users. You have pedestrians, you have bikes, you have cars, you have slow-moving vehicles mixed with fast-moving vehicles. This is the way most of the globe operates for transportation, and has a super high risk of fatality because you're mixing road users. A more standard US road is in the middle here. No highway dividers necessarily, but only one major type of user on the road, fast-moving cars. And then if you move to designing a safer roadway all the way on the left, you wind up with putting in barriers, really focusing how the traffic can move, and you decrease the risk of moving people across the same stretch of distance to 1 fatality risk per kilometer per year. So enough basic background. But what all this kind of amounts to is looking at injury with more of a public health model, define what the problem is, identify what the risk and protective factors are, either to the individual or to the system, develop and test prevention strategies, and then ensure widespread adoption. And there's been a lot of successes, and there's been a lot of successes here as well. And think motor vehicle crash is certainly one of them. If we look at the percentage of teens in high school over 16 years old who drink and drive, has decreased by more than half over the past 10 years. That's really a phenomenal success that's based on many, many things. And so when we think about injury, and when we think as a department and a school and a university of how we're approaching injury and decreasing injury in our society, we're thinking about it at the patient level. That's most often where we're thinking about it. We're also thinking about it in the environmental level. How do the parents and peers and environment play in? How does our community play into the community resources that are available? And then what are the societal influences to, let's say, increase the car company's interest in changing the way the vehicles are produced? There's many places that interventions happen and injury prevention can happen. We tend to focus on the healthcare part up here in the blue. But really, I've long learned that they're all incredibly interlaced to have success. So moving away from Sweden, a little closer to home, in 1985, Injury in America, an institute in IOM, report came out calling injury and violence the last major plague of the young, and declaring that something needed to be done, that injury could be preventable, that violence could be preventable, and that promotion of injury control is a scientific discipline and a move away from a fate-based accident approach to injury prevention and control. Recommending the CDC as the lead federal agency to build the injury prevention field, and the creation of academically based centers of excellence for injury to drive the scholarly development of the field, training and health professionals and other scientists in injury research, and the basic concepts of injury control. So in 1987, they established the first 5 academically based centers of excellence, which were called ICRCs, Injury Control Research Centers. This number rose to its peak level, hopefully, probably that we'll ever see, which was 13 in 2008, and has dropped to 11 since then with cuts in funding. And the focus of these centers really are to reduce the incidence and severity of injuries. And again, what do I mean by injury? It's mostly prevention. There is some focus on acute care also, but really mostly they're focusing on prevention. Intentional injury violence, so reducing homicide, suicide, intimate partner violence, reducing motor vehicle crash, falls, drowning, with a broad systemic approach. So how does that fit into our department? We're here to talk about our department today, so that's the CME portion largely. How does this fit into emergency medicine? Well, Bill, you came here in 92, is that right? So 92. So emergency medicine, we weren't quite a department yet, but we were still, as the field of emergency medicine, thinking about the general safety net of patients. We have a teachable moment, which we started to think about a place to interact with patients, to think about injury prevention and control. We certainly all see 1/3 of our patients that come in are coming in for injuries. It's a lot of our patients. That's one of the reasons we don't get very excited about it again, right? 1 in 4 Americans come in for medical attention for injury every year. And we were already pretty good at looking at the state of the art for acute care in emergency medicine. So thinking a little bit about how we got started in injury specifically, the fine Professor Mayo sitting up on the right, and I love this picture, Bill, from it has to be the early 90s, the CDC had just started up this call for action. 5 centers had been formed. There was another call out. Certainly we should have one of these centers here. We should have a focus on injury research. This was cutting edge at this time. And in 1997, Bill and Ron joined together, receiving some small funding at that time from Bill and a graduate student, master's level student at that time to work with Ron. Which was really just a tremendous amount of vision at that time for thinking about injury and injury control. Again, 1985, Injury in America was published. 1997, the U of M Injury Research Center was founded by Ron. And that was early on clearly a team approach. I talked a lot about that public health model. We had collaborators from the start at UMTRI, the University of Michigan Transportation Research Institute, which many of you should be familiar with by now. Ron Mayo, Gene Shope, Fred Blow, collaborators in psychiatry, really growing together to think about early injury and injury prevention as it related to emergency medicine. And one of the first projects that really was a largest project really at that time, I'd say, Ron, is a computerized intervention. Now, computerized intervention now, people shrug their heads. Remember, this was 1998. A computerized intervention in the emergency department in 1998 was a big deal. We didn't have computers in the emergency department in 1998. We still all had paper labs, 1999. So computers in the ED, put them in front of patients. Would they do it? Would they get broken? What would happen? Can we do this? There was no internet. So the first study that was the major focus of the Injury Research Center at the time was an alcohol intervention for teens, looking at teen drinking and driving with collaborators, again, from UMTRI and from psychiatry, looking at how we could do some harm reduction with our teen patients while they were in the emergency department. Early building blocks from which a lot of things grew on. And so teens came into the emergency department then, were randomized both at Hurley, already utilizing both of our sites, which have still been so integral to the center's growth since then, and collecting information and giving youth information on ways that they could decrease their drinking and driving. That was a 3-year CDC grant, which was really the stepping stone for much of the early intervention work and later work of the Injury Research Center. It quickly grew, that 3-year grant, into a computerized intervention for admitted trauma patients with Dr. Ehrlich, a web-based violence intervention that was part of my research fellowship. Again, web-based, 1999. Not a lot of web in 1999. So we were on the edge of things from the beginning with technology, thinking about injury. Web-based college alcohol intervention program, which was university-wide, and eventually grew into Safer Teens. So moving on from Ron's focus of initial work, I'm going to spend a few minutes just talking about some of the earlier projects that were in the Injury Research Center during those middle years before we really ramped up, and some of the work that was going on, and then we'll talk a little bit more briefly about where we are with the center today. So looking at that very interesting computer platform and thinking about, during my research fellowship, what Ron had done with alcohol in teens in the emergency department, having worked up at Hurley a bunch, started to think a lot about violence. What could we be doing to prevent violence and violence among kids that we were seeing coming into the emergency department? And this slide shows that what we know is that the kids' first interaction with serious violence happens right here in the ages between about 12 and 20. And if we're going to have an impact on later serious violence, we really have to focus on doing something during this critical time point with kids. We know in Flint, where many of us have and worked clinically and continue to train so many of our residents, it teeters between the 1st and the 5th of the homicide rate in the nation. And so provides an unfortunate but fabulous laboratory for us to really try to do good work in violence prevention. But it still seems a little nonsensical. Violence interventions, really in the ER, we're kind of busy. People come in already plenty sick. We see plenty of penetrating trauma. Is this logical? Can this really make any sense? What could we do, having spent a fair amount of time in the trauma bay? What could we do seeing penetrating trauma after penetrating trauma? What could we do before this person came in? Thinking more of that public health approach and more of the Hayden matrix. Let's see if I can make this work. Oops. It might be linked. I love this video. I have to wake you guys up for a little bit. Will the sound be on? Well, you can watch it even if the sound's not on. So you have to think about what happens before the kid comes in. First person to tell me where this is from. Thank you, people. So what happened before the guy came into the ED? That's sort of what happened. And how do you sum that up in a less technical way? a bunch of kids were hanging around trying to do something to pass the time. They got into some stupid argument over something stupid. It escalated over some petty remark or rumor, and then it escalated then to a later fight that somebody wouldn't walk away from, either because they didn't have the skills or they couldn't want to lose face. And then somebody pulls out some more lethal method of injury, either a knife or more currently a gun, and then there you go. So how do you stop that from happening, from coming into the ED? And what are the steps that we can think about to do that? And I like that tape historically because it just points out the differences between that and a lot of what we see come in for the kids. The ethnic minorities have changed somewhat, although not tremendously. The type of violence has changed somewhat from knife to gun. And the gender roles are not anywhere near as standard as that clip was. So thinking about how we can back that up and how we could back that up a little using some science and thinking about that Hayden matrix and thinking about some theoretical underpinnings, drawing from our colleagues that were working on substance use and brief interventions. How do we change behavior for high-risk kids? Some of the behavior has to do with alcohol and substance use. Some of it has to do with violence. How do we move the needle on some of that behavior change? And so in the earlier work, we drew a lot from screening and brief intervention. What could we do in the brief time that we have kids while they were in the ED? And out of this grew the genesis for our Safer Teens project. Safer Teens was a project in which we decided while the kids were in the ED, we would develop an intervention program for them while they were sitting around during our quite long wait, which, thank you, Jeff Desmond, is now not quite as long anymore, but used to be longer, which my RAs really appreciate, so we're not at all a fan of you shortening it, I might add. So what could we do during the time that they're there, that they're a captive audience? We know that the highest risk kids are coming in 4 or 5 times a year. We have plenty of time to see them. They're not in school. They're not in their primary care office. Who else is really going to give them any message? So we could give them a message. Let's give them something while they're there. What could we do? Drawing on that brief intervention concept, we developed Safer Teens, which was an alcohol and violence intervention for kids coming into Hurley that were 14 to 18 years old. We screened over 3,000 kids during an almost 2-year time period. We included over 700 in 3 groups, a computer group, a therapist group, and a control group, and followed them for a year. Those 2 groups each got a separate intervention that was theoretically based. They sat around, and for those of you who've wandered around the ED and don't know what my RAs are doing with those little computers, they're handing them tablets and they're answering little questions like this. When were you in a fight? How much were you drinking? What were you doing? What started it? And then following that initial assessment, they either got handed in the computer condition a full tablet and they spent the rest of the time sitting on their own with their headphones on in between getting their tests done, getting this intervention, or a therapist sat down with them and talked for 30 minutes about their risk behavior in a brief, structured, motivationally interviewing, grounded format. Let's see if I can make this work. Whoops.
Thanks for answering the questions. Now I'd like to spend some time going over your answers. We'll talk about what's important to you and teens' experience with drinking and fighting. These might not be things you do very often, but the reason we're talking about them is that these are common reasons why teens come back to the ER.
The interventions are all tailored. They're tailored by gender. They're tailored. The kids pick a buddy to walk through their interventions. They pick a girl, they pick a boy, they can pick somebody who looks like them or somebody who doesn't look like them. And they moved through these interventions, and then we evaluated the outcomes. And we found that at first, at 6 months following the intervention, the brief intervention in the emergency department decreased violence for the kids for the 6 months following their session. The therapist intervention alone, the single session, 30-minute intervention in the emergency department, decreased the amount of kids that were having fighting over a 6-month time. We recently published the 1-year outcomes of this, where we found that intervention effect was sustained up to 1 year. We have also effects at 6 months in decreasing their alcohol use, and have recently found that there was a dating violence component to one part of the intervention for kids that express dating violence. And at 3 and 6 months, the computer condition actually alone decreased the amount of dating violence kids were experiencing at 3 and 6 months, really showing that we can do something during that time that they were in the ED. We found from Safer Teens that we had something that we all knew already. The kids have high rates of violence who live in Hurley and who are coming into the emergency department. that the therapist's brief interventions show promise for preventing violence for up to a year post the ED visit, and that computers are a really appealing strategy to use everyone's time well. So where do we take that next? We have translational studies that are rolling that program out in CHOP and Grady in Philadelphia and Atlanta. We have just submitted a full R01 focusing just on the dating violence component. We have partners in London who are trying to translate Safer Teens into the west side of London. And then we also worked heavily with the School of Public Health to get a separate CDC-funded center focusing just on youth violence in Flint. The next place that violence intervention went in the Hurley ER and in the Injury Research Center during those middle years was this Flint Youth Injury Study, where we chose to focus just on the highest risk kids who come in for assault and look at them compared to their peers and try to understand better what interventions we could have just for those kids. So for those of you floating around Hurley, we've managed to successfully recruit, and these slide is hold here, but about 1,500 kids who came in consecutively with assault, and we're following them now for 2 years. We've followed 80 to 90% of them over the following 2 years, looking at their criminal justice outcomes, looking at their mortality, 5 have died, looking at their other medical outcomes, as well as how many come back for violence and how many don't. Just because we all think that all the violence happens by 2 dudes on the porch, I just thought I'd throw this slide up. It actually isn't all by 2 dudes on the porch. It's the violence where the fighting is occurring is happening mostly at people's houses, mostly often in the street, sometimes in bars. But these are kids that aren't yet, either have the money or the age to really be frequenting bars. Violence, which we know from the numbers but is difficult to believe, is not a stranger phenomenon. Only a small amount of the violence that happens is by somebody who was jumped by a stranger. The vast majority of kids that are coming for assault are coming for assault by peers and friends and people that they know. From a prevention standpoint, that's excellent, because those are people that you can really, that's something that's more fixable than stranger violence. This, again, grew into partnerships with the School of Public Health. During this time, work in the Injury Research Center and in the department really exploded, and we started collaborating all over campus. We developed very close ties with the School of Public Health and got a separate full CDC-funded center, of which there are now 5 in the country, which focus exclusively on violence. We now have 2 sections of Flint, which we have cordoned off into an intervention area and a comparison area, and have full court press going in the intervention area and multiple modes of on that Hayden matrix to try to impact how we can decrease violence and youth violence in that area. And I just want to take a moment here to talk a little bit about the Injury Center projects and Hurley, which has really been an invaluable part of our departmental portfolio, as well as a really important part of our work in the Injury Center. Through years of great collaborations with Mike Yegi and Bill, feeling that having the vision of how this extends our departmental mission. And just a few highlights here, I might say. So in the Injury Center alone, 7 R01 grants based in emergency medicine at Hurley, K Awards, R21s, 2 CDC grants, the YVPC Center, which is involved, more than 15 residents, postdoc students, uncountable total amount of postdoc students around the university working on these projects, medical students, public health students, all have gained health disparities research experience at Hurley Medical Center. And the patients there, I can easily say, have benefited well also from our projects because many of it is prevention and intervention. Many have received, 2,000 have received free counseling sessions that would otherwise not be affordable and not paid for health insurance. We've screened 3,000, 5,000 people through the Hurley Emergency Department, provided free HIV testing to 800 patients in the Hurley Emergency Department. And so it's been a great partnership for us. And those were the middle years of the Injury Research Center here in the in the early 2000, 2004 time period. And then we really ramped up after that. We decided that we were going to start to look ahead towards the next round of funding from the CDC, and we merged our departmentally based center at that point that Ron had founded of the IRC with a center that was growing at Umtree with Jean Shope, who started a SIPI center in 2008. And we merged forces and became a campus-wide U of M Injury Center with lots of support and introductions from Bill all over campus and John Younger to help us get to know the people who might really want to join forces with us. And at that point, we joined again with the medical school, with UMTRI, the School of Public Health. We got internal and institutional funding to start pilot programs and started to fund investigators around campus with a pilot RFA. Started really ramping up faculty seminars, growing our membership, lunchtime seminars, really having more of a university feel for the center. Again, 2010 to 2012, real big push during those years. And then today, so where are we today for Injury Center? So thinking back to the CDC's original vision when they joined these first centers in the early 1990s, we now have 11 injury control research centers across the country. They're funding for 5 years. They have 2 offset cycles, and we recompete every cycle. Our funding sources at this point, as we applied for our current application, were broadened out quite substantially from the department. We've started to have industry partners at OVPR across the university, including Rackham, MISHAR, and the School of Public Health, UMTRI, have all joined forces together with us for this, growing this with a vision that started here in emergency medicine to something really much more broad. And the purpose, again, of the ICRC is to build a scientific base for injury prevention, a real focus on multidisciplinary solutions, which could grow certainly from our experience in the emergency department, but really with partnerships through our engineering collaborators, psychiatry collaborators, public health collaborators, can come to solutions that we're probably not going to come to on our own, and education. So what are the current ICRCs in the country now? Well, we're happy now to be one of them. We put ourselves at the top of that list very selfishly. Columbia, Emory, Johns Hopkins, Washington, West Virginia. The other, West Virginia and Emory are the other 2 on this list that have leadership in emergency medicine. The rest have leadership all in schools of public health around the country. We really are the only one of those that has such strong ties. Emory has a very strong ties with their School of Public Health, Deb Howery. But the rest of these do not have as strong a ties with their medical school and the School of Public Health. And this is a real strength of how we got here today and why I think that we'll have good success in continued injury research. So we moved from that 1985 to Injury in America, and from Bill and Ron's vision in 1997 to 2012 with receipt of CDC funding. We grew out our organizational structure quite a bit from what was from Ron and Mary in 1997, and then from our space in NIB. We now have Associate Director in the School of Public Health, Mark Zimmerman. We have internal and external advisory committees, and we have 4 separate cores, each led by faculty in at least 2 schools across the university, joining forces to help us think about big vision and how we can approach this wide problem of injury control. We also have leadership at 2 other universities, MSU and WSU, joining forces with us. We're focusing both on intentional and unintentional injury. Some of the centers across the country have focused very narrowly, and many have focused broadly. There's one focused only on traumatic brain injury at this point. There's one focused only on suicide research. We are focused much more broadly. We have a current membership of about 150 with a membership drive this fall with a goal of 250 by spring. Now are represented well by 14 departments and 3 academic institutions with 20 practitioner institutions joining forces. I love these word maps. I always was trying to find a reason and a way to use them, but when you put them all into your computer and you see the titles of the people that are joining forces with us, this is the word map that emerges, and it's multidisciplinary at its core. What makes our injury center now unique, that's grown out of emergency medicine, is really the expertise and wide of researchers across the university with a diverse and completely multidisciplinary nature, and the partnership now of 2 other institutions which hopefully can reach impact across the state of Michigan. We're fortunate here, with unintentional injury being such a prominent and important part of our mission, to be close to the heart of the auto industry with connections to industry and resources, and also unfortunate enough to have unique needs around violence and a diversity of terrain, both rural and urban. We have 4 cores: an outreach core, a training education core, and a research core. Our research core focus is to recruit new and established researchers to participate in our program of research to really promote that interdisciplinary work. How are we doing this? The core leadership is Ray Bingham at Umtree and Maureen Walton in the Department of Psychiatry. We are sponsoring an annual pilot studies program. Again, 25K pilot awards, 4 to 6 every year. Roundtable discussions quarterly by research groups focused on spin-off projects and how we can really expand and accelerate the current projects that we have going on. Enabling easy access to injury data sets, providing statistical consultation with our stats and methods core. And then we have 4 funded projects as well that are funded as major center projects by the CDC. One of those is the Translating of Safer Teens Intervention that I talked about in depth before. One is a pilot test of prescription overdose intervention, which will happen in our emergency department as well. That's led by Amy Bonhart. Making the most of supervised driving. For all of you who have teen drivers, we'll now have an intervention guide for how we're actually supposed to teach those drivers to hit the road safely, as well as examining graduated driver's licensing options. We've funded now 12 studies across campus for past and present pilot studies over a wide range of topic areas: risky adolescent driving, child abuse and neglect, child maltreatment, teen driving, cell phone bans, crash warning systems in teen driving, teen dating violence, and one acute injury with a focus on traumatic spinal cord. Our outreach and translation core is focused on taking the science as it happens, and the CDC then provides us with the infrastructure to push that information on out to practitioners to try to really reach the audiences that will need to implement the information, as well as to just generally reframe whenever possible injury as freak accidents and help it reframe it as a preventable public health problem. We have a policy group which is focused on helping us turn to the many challenges which the legal system and the body politic seems to continue to present us with. For those of you who are somewhat confused by our rescinding the helmet law in this state this year, it was something we were very involved in trying to prevent. I do like to remind people that Rwanda instituted a helmet law the same year that we rescinded ours in the state. But we did prepare briefs and educational information to the limits of our allowable possibilities for advocacy to the state legislator, and we'll continue to do so, pulling in resources from our government relations folks here, as well as from the school public policy and school public health folks. Other things, the return to play for after concussion, which was recently passed, which was a work by many of our partners, and we're very proud of, and ongoing training for how we, who are mostly more focused on research, should also be focusing our end results to impact policy. And then finally, the last mission of the center is education. So bridging the enormous gap between who we are working with now and who will be the future people that are really working on the problems of injury. Our training education core is funded for postdoctoral fellowships, for GRSA positions across campus, for internships with many researchers around campus. We are proud we will soon have a new injury certificate program in the School of Public Health, as well as many mentoring opportunities. I just want to throw up here, and this is by no means a complete list, but just within our department, people that have worked very closely with the Injury Research Center, either with Ron or in the later iterations with myself or other faculty over the past couple years. Within our department, there's been lots of reaches and tentacles to people focusing in some way or another at some point in their career on injury research. And just a little sample now of, if people are more interested, who you can talk to in the department and who in the department is focusing on injury research at a new and upcoming level. I'll highlight just a few people's work here before I end. Michelle Macy, we looked at this data yesterday, which I find fascinating. Among many of the things she has doing is an interesting paper that will abstract, which will soon be paper on distractions among parent drivers. I find it really fascinating. I always knew that my risk of increasing my crash was tremendous as I was trying to parent in the back seat and turn around and give the kid the bottle and do all those things. And that has now been properly quantified along with texting, which I think will be a very high impact and interesting paper. Pat Carter has been involved. And now because we were so successful, this really is logic, at repealing the helmet law, There are many people in the state who actually are trying to now repeal the seatbelt law, because that would just be a good idea. So Tree and Pat had put together some data that would actually show what that would mean for deaths in the state based on past trends. That's being recently submitted. Some other work that he's starting on is on alcohol interlocks. What would happen to drunk driving, and what would happen to motor alcohol impaired crashes if alcohol interlocks were in every new car that came out. This is not a pipe dream. Actually, the head of NHTSA was here a couple days ago. They have an active program looking at how to put alcohol interlocks into cars. For those of you who don't know what they are, the engineering has long been there that your car won't run if you have alcohol on board in your car. Other countries have this automatic now for bus drivers or truck drivers or other people who are felt to have high positions for public safety. It certainly could be done. It could be mandated for some. There's lots of opportunities. There's also, we're not that far off in the auto industry from cars that drive themselves. And Tree has any number of interesting projects that are moving in that direction, and Dr. Carter will continue to keep up with them. Lauren, who recently has moved on, Sue Stern isn't here today, but moved on to join Sue Stern's regs, but was a postdoc with us for the last 2 years, has recently been focusing on what is now surpassing motor vehicle crash in the state of Michigan, which is prescription drug misuse and overdose. And she's been looking at a lot of data on that recently. Manya, if you see Manya in her office these days, she's intensely looking over heat maps of spatial correlations of violence and alcohol misuse in Flint. And VJ, who has been working on family violence and preventing aggression, more so in the primary care clinics. Suzanne Dooley-Hash, who has been looking at eating disorders and a relation to depression and suicide as well, has put out a number of papers with us over the past couple years. So how else can you engage now with our injury center, which has come so long from those humble beginnings in 1997 and the early 90s? You can become a member. Please become a member. You can like us on Facebook, you can attend seminars, you can attend courses, you can work with people in the internship programs, you can apply for our pilot study opportunities, and you can go to the website. And I just want to thank you clearly, Bill, for your vision in the early 90s for supporting the Injury Center, way before it was cool, because now it's really cool, and for leaving such a legacy of excellence that we can build on. Thank you.
Does anybody have any questions for Rebecca at this time? She ran away, so any questions? Yes, Mike.
I just wanted to bring a message of gratitude on behalf of the board at the Early Medical Center. Our board is, I don't know if everyone knows, but it's made up of community members that are appointed by the mayor of the city, so they're all active community members, and the work that's been done in Flint has really brought some impact. Now, we've had a tough year, of course, and I think we had our 62nd homicide just in the last day or two. But we're anxiously awaiting to see the next trials and to see these intervention groups and what kind of impact it's having. Number one, and number two, I would also just want to commend you on the innovative methodologies of which you're gathering data in a busy clinical environment is really quite amazing, because over the 3,000 plus enrollees in the one study, I don't recall a single episode where there was a disruption in clinical exam, the throughput, and all the types of things that take place on the clinical side of medicine, where this is a good example of how you can really be innovative and pull research data out of a clinical visit and really not have any impact in terms of how long the patient's in the department and interfering with really testing or evaluations or anything like that. So it's really been quite remarkable.
Thank you, Mike. It's, I think, for better or worse, we intersect with a lot of people in the ED, and there's a lot of time when people are there, and it's time that there's opportunities for us to do research. I've not been a big advocate that it should be the busy clinician that's necessarily doing that intervention. But as we demonstrate, which has been done now better with alcohol, there now is a code which we are not using, but has been used around the country to build for alcohol counseling, like instead of tobacco cessation. And hopefully, if we can, we're doing a cost analysis now from the RWJ's out of the Safer Streaming Program, and as we show what the cost benefit is of that intervention, and hopefully at some point we also can build for, again, for some of those preventative services to continue to disseminate things more widely, because there's an opportunity while people are in our department to do a variety of things. It's not necessarily the clinical staff that can do that, but they're there. So, and the support of Hurley has been overwhelming, and it's been an amazing place to do a lot of great work.
Thanks, Rebecca. Those of you who have heard me probably years ago give my pediatric injury talk, this is so exciting to see this center up and running. In the pediatric population, injury is the most common cause of serious mortality and morbidity. And C. Everett Koop once said years ago, if there was a disease that was killing kids at the rate that injury is, people would rise up and demand that this killer be stopped. And yet, you know, parents often still think of injury as the accident. But I think, you know, we've seen the demonstration that that's not true anymore, and we really can have an impact. We're hoping to see this go into the future.